So, as an introduction, chemical agents have been used for war since World War One, and there are very types, and the effects need to be understood in order for us to respond appropriately. And our medical management would very much depend on the types of the agents used. So, in the as for the chemical agents, there are the toxic or incapacitating ones. It is largely used for the incapacitating agent in the form of tear gas, largely used as a riot control agent, and that is still relevant today because it's in existence. But as for toxic chemical agents used in war, like choking agents, blood agents, blister agents, nerve agents, all these, like choking agents in the form of phosgene, makes you feel like, gives you problem with breathing. Blood agents in the form of cyanide, which will kill you, despite high oxygen level, because the oxygen simply could not get into the cells. Blister agents that cause all the skin become forming blisters. And finally, the nerve agents that would cause whatever holes you have in the body, water will come out, like teary eyes, vomiting, diarrhea, sweating. So all these are relevant for our cause. So recently at the Kanjuruhan Stadium in Indonesia, there was a football game and tear gas was used. So it is an incapacitating agent. Well, tear gas is supposed to be used in open place, but if people are trapped and they could not run away from the gas, they can die. So in this incident, there was 364 deaths because the spectators could not get away from there. As for nerve gas attacks, I mean, we can just have a look in terms of the history. That it was first used in 1994 by Japanese scouts, and in that incident, 7 dead and 200 more injured. But in 1995, there was a second attack, and this was very famous, the use of sarin gas. 12 died, but 6,000 were injured. It was released in Tokyo Underground Station. And in 2013, there was a sarin gas attack in Damascus, Syria. So this was the event of the Tokyo sarin gas attack in 1995. There was chaos in front of the hospital, and you could see all this, some stains, indicating the vomiting. So we have to be prepared because this can happen at our doorsteps. Well, in Malaysia, we have our preparedness program. We train for chemical incidents. So this is an example of chlorine gas drill in 2007, and we had our hazmat team responding like this, and as they respond, the patients would be decontaminated, and once decontaminated, it will be handled by our medical team. Recently, we also had this this drill, big drill, in 2022, just about a month ago. And in the drill, there was a release of nerve gas. And there was also integration of our bomb squads and everything. So all drills are important to prepare us for this eventuality. So as for the chemical and fire incident, we had a drill some time ago, and in this drill there was a makeshift terrorist lab that produced nerve gas, and in this drill, initially everything went pretty well, and subsequently. We, all this response, our team came, responded, triaged them, put them in the appropriate zones and give them treatment. But this drill went on a second phase for which there was chemical in a situation, and this is when it becomes real. So I was a judge during that training, and at that time I noticed that there was the patients were being evacuated, and they were um, being decontaminated. Suddenly I heard that there was like 50 of these, supposed to be participants in this drill ran out from the building, and they were in a bad condition. They were nauseated, they were not stable, feeling dizzy. And actually, we were told later on that malathion was used in the drill, and there was a change of wind direction, and 50 of them were affected from malathion. So I had to change strategy. I had to become a responder, become a doctor, and responded in that drill. So what we did was that we performed the triaging, because suddenly everyone just came and bypassed the decontamination station. So what we did is that we directed them, those who could walk, we directed them to our green zone, and over there we asked them to disrobe, remove their clothes, and for them to take shower on their own. For those who were worse, we placed them in the red and yellow zone. Again, we remove the clothes and put them in plastic bag, just until their underwears, and immediately move them to the hospital. So this was patients being moved to the hospital. They were real patients for what was intended as a drill. So at the hospital, they did just using the wet wipes. They just wiped the patient out, because the effect was not much anymore after they removed their clothes. So this was the patient that were at the green zone, or the green triage zone, and they were asked to subsequently shower on their own to remove all effects. So those who could walk, they were not taken to the hospital. They were quite well, and they were treated at the nearby clinic. So for those patients there were 6 patients who admitted, and they were observed overnight, and subsequently they were discharged the next morning. However, there was one patient who was not well, young patient. He had muscle fasciculation, blurring of vision. The eyes were teary, but still conscious. So for this patient, we gave a total of 15 milligram of atropine, and he didn't do very well. So we had to send him to the hospital. To the major hospital, because this hospital was a district hospital near the incident site. So they did not have any anesthesiologist or ICU. So patients were sent to a major hospital, intubated, and placed in the ICU. Apart from atropine, pralidoxim was also given for this patient. And these were the rest of the patients who were quite alright and discharged the next morning. So malathion is an organophosphate, and used as a pesticide. So the effect of malathion could be in the form of muscarinic or nicotinic effect. In the form of muscarinic, the symptoms, what we call sludge symptoms, in the form of salivation, lacrimation, urination, diarrhea, diuresis, GI cramps, and emesis. In the form of nicotinic, it causes what we call a Monday to Sunday syndrome. Monday refers to muscle cramps, Tuesday tachycardia, Wednesday for weakness, Thursday for twitching, Friday for fasciculations, Saturday for seizure, and Sunday for sugar or hyperglycemia. So basically what organophosphate does, this is what organophosphate does. It blocks the acetylcholinesterase enzyme at the neuromuscular junction, and when it does this, it stops the process of breaking up of acetylcholine. Therefore, there's a surge of the acetylcholine level that give rise to the accentuated acetylcholine effect, and it affects the acetylcholinas, the 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 neuromuscular joint, whereby there's the action of acetylcholine, the acetylcholine receptors, and this can be at the skeletal muscle that could cause fasciculation all, because this is a nicotinic effect, and it could affect the autonomic nervous system, either the sympathetic or parasympathetic. But if you look at the autonomous nervous system, the sympathetic nervous system would require acetylcholine and noradrenaline receptor. So the effect would not be direct, and therefore it's less in terms of tachycardia, hypertension, or mydriasis. But it tends to affect the sweat gland directly, causing sweating, or also for parasympathetic nervous system, the receptors are purely acetylcholine, and therefore you will get more the effect of bradycardia, all the parasympathetic effects of the patient. And it's common to see patient having the eyes mydriatic, in the sense that the pupils become small. So in terms of the strategy of management, it's the same with the ABC, like handling any patients in emergency. But you need to give the antidote in the form of anticholinergic drug, in the form of atropine, and also an oxime in the form of pralidoxime to reactivate the inhibited acetylcholinesterase. So it helps to remove the binding of the organophosphate to the acetylcholinesterase enzyme. And if patient is having seizure, an anticonvulsant would be warranted. In terms of decontamination, the patients need to disrobe themselves, and ideally should shower with water and soap. The alkali is ideal to hydrolyze the organophosphate. The best is to remove clothes. Once the clothes are removed, 90% of contaminants are removed, and the rest is just water and soap. So these are the levels of PPE, level A, B, C, and D. Ideally, we should be wearing level A, but it is not readily available, and you cannot last more than 30 minutes. And it takes a lot of time for you to be in that suit. So you have to make do with what we have, and you could still protect yourself. We can have at level C if we have. When we can't, there's no choice, because at the hospital with the limitations, then you could at least use the N95 mask with the nursing barrier, and making sure that patients the garments are removed, and you could handle once all the garments are removed and patient had been cleaned. So beware, because you can become a victim yourself. Ideally, we should rope in the hazmat team to help us perform the decontamination, and we could handle the patient with the patient being in a decontaminated state. So this is an example of the hazmat. You remember, you also have the military who also train with this chemical incident, so they can help to wash the patient, with water and soap after disrobing patient. Again, this is resuscitation. You may be focusing on the bronchoria, bronchospasm, and seizure. So some of these patients may have to be intubated, but beware of using succinylcholine, because it is degraded by plasma cholinesterase, and because of this agent, it may result in prolonged paralysis. So other agents like rocuronium is much preferred. So atropine is the antidote, and one can start with the first dose, and can double the dose if it has not dried up the secretions. Because the main thing is that the secretions that could kill the patient, the secretion, the bronchospasm, and the bradycardia. So once atropine is given, we target so that patient is slightly tachycardic. There is it's dry, and that would save the patient. Need be, after the giving of the atropines, infusion could even be warranted for such patient. So this is a pralidoxime. It could be given just as a infusion. If required, it could be followed by infusion after being given over anything between 15 to 30 minutes. So it helps to remove the binding of the acetylcholine of the nerve of the organophosphate to the acetylcholinesterase enzyme, and I talk about the malathion and organophosphate, but the truth is that this organophosphate is the basis of all nerve gas agent compounds. These are examples of nerve gases used in war, like tabun, sarin, soman, GF, VX, and they all have variable aging time. So meaning that the time that they get bound permanently. So apart from that, we also have VX in Malaysia. Would you believe it? We had we didn't have experience with sarin and the rest, but we had an incident of VX in Malaysia. So in 2017, there was this news that Kim Jong-un, half-brother of the then president of the North Korea, was assassinated in Kuala Lumpur in Malaysia. This was him. He was like an estranged brother, and did not even live in North Korea. He traveled to Malaysia, and apparently in Malaysia, a lady put a cloth that was wet and wiped his face with the cloth. That lady was wearing the LOL shirt. It was caught on the CCTV, and that man finally died. When he presented, there was a small pupil, and he died. After the investigation from the forensic, it was found that there was a VX nerve agent found on patient's face. So that was VX attack, and it is still an organophosphate agent and used as a weapon of mass destruction. Only 10 milligram can kill within 15 minutes. Yeah? Same, it works by inhibiting the acetylcholinesterase. It's tasteless, odorless, amber-like color. It has high viscosity, low volatility, and it's very oily. And in fact, the first documented VX use was still in Japan by the same cult, the Aum Shinrikyo, and they used VX on 3 people who suspected as spies, of which one died. And how they did it was by just sprinkling the VX on the neck on the street. That patient died. So in the conclusion, chemical agents had been banned worldwide, but it's still being used by terrorists in milder form, all over the world. Chemical agents in the form of tear gases are still being used. Although the tear gases would not kill patient if patient or people run away from the gas, but they could still die if they are in close environment. So we have to beware of this, not to use the tear gas in close environment. All nerve gases basically has organophosphate compound, and they block acetylcholinesterase enzyme and prevent the dismantling of acetylcholine and makes its effect accentuated. And the effects are basically either sludge or the Monday till Sunday syndrome. Uh, Managing nerve gas patients are exactly like managing any organophosphate poisonings. One should have a high index of suspicion when somebody comes to the hospital complaining that the world had become smaller. And this is because the pupils become uh, constricted, small pupils, making them see the world becoming smaller. So if you see this, I like to tell my staff that 1 is an incident, 2 is a coincidence, but 3 is a trend. When you see a trend, people keep coming in front of the triage counter saying that the world is becoming smaller, there must have been an incident. Decontamination is necessary, and you can start with something very simple by removing the clothes, for which 90% of contaminants are removed, and the other 10% is to shower with soap. Those who could shower themselves, ask them to shower themselves, but those who can't, we will have to assist them. Rope in the hazmat team to assist in removing and showering them, and so that the doctor would not be affected. Practice for the unexpected because the unexpected has become the expected. So expect the unexpected. So with that, I thank you, and I hope that it is a good conference over there, and I'll do my best to answer any questions. Thank you.